Welcome to this deep dive. Today, we're taking a stack of notes specifically, some MSRA pediatric revision notes on a really common childhood condition.
That's right, gastro-oesophageal reflux disease, or GRD, in children.
And our mission is to, pull out the absolute key information from these notes.
Make it clear, high yield, and give you those nuggets that will stick, whether you're revising or just want to understand this topic better. We're focusing strictly on GORD in kids today.
It's something so many parents encounter, and definitely important for medical professionals. So let's dive into these notes and see what we can learn together.
Let's do it.
Okay, so let's start with the basics. What are we even talking about here? The notes distinguish between GR and GORD right at the start.
Yeah, and that distinction is crucial. Gastro-oesophageal reflux, GOR, is described as the non-forceful regurgitation of milk and gastric contents. Stuff coming back up into the esophagus.
Okay.
The notes say this is normal in young infants. It's different from vomiting. That's an active, forceful process. This is more passive.
So GOR is kind of just a normal baby thing, like spitting up.
Exactly. Physiological reflux happens in everyone, just less often in adults and older kids. But in babies, it's super common.
Right. So what makes it GORD then? The disease part.
Gastro-oesophageal reflux disease, GORD, that's when this reflux becomes persistent, frequent, causes troublesome symptoms, or, importantly, leads to complications.
Okay.
The notes define it as that backward flow causing symptoms or complications, often because the lower esophageal sphincter, the LES, is relaxing when it shouldn't.
The valve at the bottom of the food pipe.
Precisely. So think GRR, normal, common baby spit up. GORD, that reflux causing problems like pain, poor growth, or other issues. It's the disease state.
Okay, that makes sense. Normal versus causing trouble. So if GORD isn't just normal reflux, what actually causes it? Why does that valve fail?
Well, often the exact cause is unknown, but the notes highlight a few potential factors. A big one is immaturity of that lower esophageal sphincter, the LES.
Especially in babies, I guess.
Exactly. It just might not be fully developed or coordinated yet. Then there can be issues with the esophagus's motility, how well it moves contents along, or sometimes increased pressure within the abdomen, pushing things back up.
Okay, so it's about the valve, the pipe movement, or pressure. Are there certain children who are more susceptible? Risk factors?
Yes, the notes list several. Prematurity is a big one, which ties into that immaturity idea.
Makes sense.
Also, certain medical conditions, like neurological issues, think cerebral palsy or specific gastrointestinal abnormalities. These can affect muscle control or structure.
Right, things affecting the muscles or the anatomy.
Exactly. And a family history of GER is mentioned. Interestingly, even parental heartburn or acid regurgitation is listed as a risk factor.
Huh. That is interesting. What else?
Other things mentioned are obesity that increases abdominal pressure, right? Having a hiatus hernia.
Where the stomach pushes up.
Yeah. Also, a history of repaired congenital diaphragmatic hernia or repaired congenital esophageal atresia, previous surgeries affecting that area. And neurodisability comes up again, broadly.
That's quite a list. Prematurity, neuro issues, structural things like hernias or past surgeries, obesity, family history. Seems like a mix of developmental, structural, maybe even genetic factors.
Yes. It helps to kind of group them in your head, things affecting the valve directly, things increasing pressure, things related to development or underlying conditions.
Good way to think about it. So we've touched on the LES failure, but just to be crystal clear on the pathophysiology, how does it work?
Simply put, the core issue is that failure of the LES. That sphincter acts like a one-way valve. When it doesn't close properly or relaxes at the wrong times, it lets stomach contents, including acid, flow back up into the esophagus.
And that causes the irritation.
Precisely. That acidic reflux irritates the lining of the esophagus, and that leads to the symptoms you see, like pain, crying, or inflammation.
Got it. Okay, so when a child has symptoms that look like GORD, spitting up, fussiness, what else could it be? What are the differential diagnoses?
Good point. The notes list several things to consider. There's functional spitting up, that normal GOR we talked about, then GORD itself, obviously.
Right.
But also things like eosinophilic esophagitis, which is more of an allergic inflammation, and other general gastrointestinal disorders need to be considered too.
And this is where it gets really interesting for anyone trying to figure out what's going on. The notes give that list of red flag symptoms, the things that suggest it's not just GORD.
Exactly. This list is vital. You have to know these. The red flags mentioned include frequent forceful vomiting. Remember, GORD is usually effortless.
Okay, forceful is a key difference.
Bile-stained vomit, green or yellow, suggests a blockage lower down. Vomiting blood, which is hematemesis, Symptoms starting after 6 months of age or persisting really strongly after 1 year that's outside the usual pattern.
Right, the timing is important.
Blood in the stool, signs of abdominal problems like tenderness or distension, chronic diarrhea, fever, or the child just generally appearing unwell.
Other signs.
Painful urination or dysuria. A bulging fontanelle in infants, the soft spot on the head. A rapidly increasing head circumference. Altered responsiveness, like being unusually sleepy or difficult to wake. And signs of allergy or atopy in infants or children.
That's a comprehensive list. If you see those, you need to think beyond simple GORD.
Absolutely. Those symptoms demand investigation for other, potentially more serious causes. Let's try a quick scenario. Imagine you hear about a 4-month-old baby, usually happy, who's been spitting up more, seems really irritable after feeds, arching their back, but is gaining weight okay, no fever, vomit is just milk. Any red flags jumping out there?
Well, the irritability and arching fit GORD weight gain is okay. No fever, no blood, no bile. Sounds more like typical GORD presentation, not hitting those red flags. Right?
Exactly. That pattern fits the clinical picture of GORD needing management, but doesn't immediately scream emergency investigation based on that list. Now, contrast that with, say, a 10-month-old starting to vomit forcefully, maybe some bile, looks lethargic.
Okay, that sounds different. Forceful vomiting, bile, lethargy, onset after 6 months. Multiple red flags there. Time to investigate other causes.
Perfect. That's exactly how you use that list. Okay, so how common is this? Epidemiology.
Yeah, how often do we actually see GORD in children?
It's very common, especially in the UK, according to these notes. We mentioned GOR affects maybe 50% of infants in the early months. That asymptomatic milk regurgitation, pausetting, is noted as common and harmless.
Wow, 50% having reflux is a lot.
It is. And significant GORD is also common in infancy, the notes say, affecting at least 40%. It typically begins before 8 weeks old and can be frequent, sometimes 6 or more episodes daily, as mentioned.
That sounds incredibly stressful for parents. Does it usually get better?
Good news there, it typically becomes less frequent over time and, as the notes highlight, resolves in 90% of affected infants by the age of 1 year.
90% by 1 year. That's reassuring.
Yeah, the notes even break it down further, 55% resolved by 10 months, and the vast majority by 18 months. It can still happen in older kids and adolescents, but the peak incidence is definitely in early infancy.
Okay, so very common early on, but usually resolves. Now, let's recap the clinical features. What symptoms would you actually see?
Right, the classic presentation in infants, as the notes list. Frequent spitting up or that effortless vomiting, irritability during or after feeding, poor weight gain or faltering growth, excessive crying, and that characteristic arching of the back during feeding.
And older children. You mentioned heartburn earlier.
Yes, in older children and adolescents, the symptoms often mirror adult reflux. Heartburn, retrosternal pain, that's pain behind the breastbone, and epigastric pain, which is upper abdominal pain.
Are there other, maybe less obvious symptoms across different ages?
Yes, the notes mention quite a range. Recurrent regurgitation or vomiting, obviously, but also things like choking episodes or even apparent life-threatening events, ALTEs.
That sounds scary.
They are. Also, respiratory problems can be linked to things like a chronic cough, pauses in breathing, apnoea, recurrent wheeze, and rarely aspiration pneumonia if contents get into the lungs. You can also see feeding and behavioral issues, and that failure to thrive or faltering growth is a big one.
It really covers a spectrum. You could almost group them like you've got the immediate feeding and tummy issues, then the respiratory stuff, and then the growth and behavioral impact.
That's a good way to categorize them, yeah. It helps organize the potential presentations. So, with all these possible symptoms, how do doctors actually figure out if it is GORD? Investigations.
How is it diagnosed? Do they always need tests?
The notes are very clear here. Diagnosis is primarily clinical. It's based mainly on the history, especially that pattern of effortless vomiting after meals, combined with the other symptoms we discussed.
So investigations aren't always needed then?
Correct. In mild, typical cases, investigations are usually not required. You often treat based on the clinical picture.
But they become necessary sometimes.
Yes, definitely in severe or unclear cases, or for infants and children who have those red flag symptoms we talked about, or specific complications.
Okay, so what kind of tests are done in those situations?
The notes list several key ones. A 24-hour ambulatory esophageal pH study is one. That measures how often the pH in the esophagus dips below 4, indicating acid reflux.
So it quantifies the acid exposure.
Exactly. Then there's a barium meal. That's an X-ray study where the child drinks contrast liquid. It helps rule out anatomical abnormalities in the upper digestive tract, like a blockage or malrotation.
Useful for structure. What about looking directly at the lining?
That's endoscopy. An upper GI endoscopy involves putting a camera down to look at the esophagus lining. It's used when inflammation, esophagitis, is suspected. They often take biopsies at the same time.
To check for microscopic changes.
Right, or other conditions like eosinophilic esophagitis. And then there's manometry, which assesses the muscle function of the esophagus and how well those sphincters are working.
So different tests for different questions. pH study for acid, barium for anatomy, endoscopy for lining damage, manometry for function.
Precisely. And the notes specify when certain tests might be particularly indicated, like an upper GI contrast study, like the barium meal, for unexplained bile-stained vomiting or difficulty swallowing.
Okay.
Esophageal pH studies are considered for things like recurrent aspiration pneumonia, unexplained apnoeas, or even dental erosion, especially if the child has a narrow disability.
And there was that interesting point about UTIs.
Yes. The notes remind us to investigate for a urinary tract infection in infants who have regurgitation, along with faltering growth, late onset regurgitation, or marked distress. It's a reminder that symptoms can overlap.
So bottom line on investigations. Clinical diagnosis first, tests reserved for severe, unclear, or red flag cases, and the choice of test depends on what you're trying to rule out or confirm.
You've got it.
Okay, so if a child is diagnosed with GOD, what are the management options? What can be done?
The notes outline a kind of tiered approach, starting with lifestyle modifications. Conservative measures first.
Like what?
Positioning changes during and after feeding, keeping the baby upright. Smaller, more frequent feedings can help so the stomach doesn't get too full.
Makes sense.
Thickened feeds are also mentioned. Making the milk or formula thicker can make it harder to reflux.
But what about positioning during sleep? That's a big safety issue.
Absolutely critical. The notes explicitly state to avoid positional management during sleep, no wedges or propping up. Always place infants on their back for sleep due to the risk of SIs. Safety first.
Right, back to sleep, always. So, if those lifestyle things aren't enough,
then medications can be considered. The notes mention acid-reducing drugs, specifically PPIs, proton pump inhibitors like omeprazole or H2RAs, H2 receptor antagonists like ranitidine, although ranitidine's availability has changed. These are for persistent symptoms to reduce the acid.
do they mention other meds?
Briefly, in specific cases, other medications like metoclopramide, domperidone, or erythromycin might be considered, but they have more specific uses, potentially more side effects, and aren't first line usually.
Okay. What about those infants with faltering growth that you mentioned, if the reflux is impacting their weight gain significantly?
For those infants with faltering growth and significant regurgitation where other treatments haven't worked, the notes say enteral tube feeding might be considered.
So, feeding directly into the stomach or bowel.
Yes, to ensure they get enough nutrition to grow properly. But the notes emphasize this needs an individualized nutrition plan and, crucially, an exit strategy to get back to oral feeding eventually.
And is surgery ever needed?
Yes, surgery is an option, typically a procedure called fundoplication. It's considered for severe intractable GRD where medical treatment hasn't worked or isn't practical long-term.
That sounds like a last resort.
It generally is, and it's usually preceded by thorough investigations like an upper GI endoscopy to assess everything fully.
So it's a step-up approach.
Yeah.
Lifestyle, then meds, maybe tube feeding for growth, then surgery for the toughest cases.
Exactly. And the notes also stress the importance of referral to a specialist for infants and children with those specific tricky symptoms, complications, or if the diagnosis isn't straightforward. An endoscopy with biopsies might be needed then.
Right, so a clear pathway. Lifestyle meds, tube feeding if growth issues, surgery, severe intractable, specialist referral, complex red flags. Seems logical.
It does provide a structured way to think about management.
This has covered a lot. So what's the typical journey? The prognosis.
Yeah.
Does it usually get better? You said 90% resolve.
Overall, yes, the prognosis is good for most cases. As we mentioned, most infants outgrow it without significant complications. The notes specifically say 90% resolved by 1 year of age, with 55% by 10 months and the vast majority by 18 months.
That's really reassuring for parents dealing with it, but not everyone fits that pattern right.
Correct. Ongoing management is needed in some cases, especially if the reflux persists past that typical age range. And surgery, while an option, is only required in a minority of patients.
What about issues in those persistent cases?
The notes do mention things that can arise. Chronic cough, wheeze, even finger clubbing, and recurrent pneumonias can be linked to persistent reflux. Adverse effects on growth and weight gain are seen in about two-thirds of patients with ongoing GOR.
Two-thirds is quite high for the persistent group.
It highlights the impact it can have. There's also an association mentioned with conditions like cerebral palsy, Down syndrome, developmental delay, and Sandifer syndrome, that posturing condition.
And other physiological issues.
The notes state delayed gastric emptying is found in two-thirds, and aspiration pneumonia in one-third of patients with persistent issues. So while the overall picture is positive for most infants, there are definite complications and ongoing issues to be aware of in those where it continues.
Okay, you just touched on some, but let's explicitly list the main complications the notes highlight.
Sure. The notes specifically list reflux esophagitis, that inflammation of the esophagus we talked about, recurrent aspiration pneumonia lung infections from inhaling reflux contents.
Serious one.
Definitely. Also, frequent otitis media ear infections, defined as over 3 episodes in 6 months.
The ear infection link again.
Yep. And finally, dental erosion, particularly noted in individuals with neurodisability, especially cerebral palsy, likely due to acid exposure on the teeth.
So esophagitis, lung issues, ear infections, dental problems, potential consequences if GORD is severe or persistent.
Exactly. It underscores why managing troublesome GORD is important, even though most simple reflux resolves on its own.
Wow, okay. We've really covered the waterfront from definition to complications based on these notes. Feels like we've pulled out the key stuff.
I think so. We've taken that raw material and hopefully made it much clearer, highlighting the crucial points about what GORD is in children, the GOR versus GORD distinction, why it happens, who's at risk,
How it presents, those vital red flags.
how it's diagnosed primarily clinically and managed step by step, and what the likely outcomes and potential complications are. Understanding that difference between normal infant reflux and GORD is just fundamental.
Absolutely. And recognizing those red flags, it gives you a solid framework for approaching this topic, whether it's for an exam or just better understanding.
And thinking about this, it does raise an important question for you, the listener, to consider. Given that basic reflux, GOR, is so common and normal in infants, and GOR can sometimes have significant complications, how do clinicians effectively navigate that line
You mean reassuring parents about normal spitting up?
while staying vigilant for those signs that actually require further investigation or intervention? It's a delicate balance, isn't it? How do you get that right?
That is a lot to chew on, a really important clinical challenge. Well, thanks for joining us on this deep dive into childhood GORD based on the notes we explored today.
We really hope this was a high-yield session for your revision or just your general knowledge base.
If you are looking for more resources, especially for MSRA revision, you might find what you need over at pastmsra.com.
And don't forget to check out freemsra.com as well. Some great free resources there, too.
Definitely worth a look. Until next time, keep diving deep into learning.